Well, hello and good evening. This is the place to be. Welcome. My name is Dr. Randy Fink, and it is time for Fertility with Fink and Friends. I am Fink. You are friends, and it is wonderful to be here as we are every Tuesday evening. At this time, 5 o'clock p.m. on the Gulf Coast, which means 6 o'clock on the East Coast. 4 o'clock in the mountains and 3 on the west. Fertility with Fink and Friends is a production of the First Fertility Network, and we are so honored to be a part of that group. My name is Randy Fink, and I am a fertility gynecologist here at New Life Fertility in Pensacola, Florida. We also have offices in Mobile, Alabama, and in Panama City. I am also a doctor at the Missouri Center for Reproductive Medicine in St. Louis, with offices also in Tulsa. And so whether you are joining from the local area, whether you are in the Midwest, whether you are on the West Coast, or even across the world, we've got folks joining from the Caribbean. We've got people everywhere. And it is an honor to be here with you tonight, as always. This is the place where we get together and talk about all those things that are important to us, things about making a family, things about being pregnant, things about women's health. And it's not just for women, guys can ask questions. We see men here talk all the time. People often ask about, well, tell me, do you only see patients in your office from your local area? And the answer to that is no. We are happy to do consultations from folks all over this great nation, no matter where you are seeking your care. I am happy to provide my opinion. Our website here at New Life Fertility is fertilityleaders.com, and at MCRM, the Missouri Center for Reproductive Medicine, it is, I believe it's MCRM.com. So easy to find. And so let's say hello to all of our friends joining here tonight. Hi, Andre. Good evening. Nice to see you over here. So we've got the Instagram page for New Life Fertility right here. I've got my Instagram right here, which is Randy Fink MD. Please do follow me if you don't. And we've got some other pages. We've got a couple of Facebook pages for New Life Fertility, for First Fertility, for MCRM. We've got LinkedIn. We've got YouTube. All manner of social media here tonight, folks. And let's see, Priest Lana, you are actually Sarah. You are the first to join. Priest Lana, you were number 2 over there on New Life, and over on mine. Hello to my friend Rosa. Thank you for being here as always. Angelina, the Fox nurse practitioner up there. Oh, and along with Nick, what a prestigious group they're joining us here from from Minnesota. And I say Minnesota, and I don't mean Wisconsin, and I don't mean it's one of those M states. I often get it tripped up in my mind. So very, very honored to have you. Hi, Veronica. Nice to see you here. Dr. Williams, our wonderful embryologist, has also joined, as well as the Bama gal, who is my beautiful mother in Mobile, Alabama, who is sitting very pretty this evening with my father. And a very special shout out to my brother, Jeff, who is joining them in Mobile from his perch up in the Boston area and in Maine. Very honored to have you all here with me tonight. Andre asks about, hey, can you talk a little bit about the Zymote device, or Zymot? Would it be beneficial for donor sperm? Well, so let's talk about what that Zymot device is. I think technically the term for it is Zymote. I believe that's how they pronounce it, but I've always called it Zymot. And so that is what I'm going to call it here. And nobody can tell me otherwise. So how you like that? So what the Zymote device is, or Zymot, what did I just say? I'm going to call it Zymot, and then I called it the other thing. The device is a sperm selection method. And essentially what happens when you're doing IVF, let's say, for instance, the embryologist will sit down with a microscope and look under that microscope and look at each individual sperm that they are going to select for each individual egg. I like to think of it as they are interviewing every one of your sperm. They interview, it's a personal interview to see, make sure their hair is done, they're dressed appropriately, that they can talk in front of other people. They interview those sperm in order to select an individual sperm for each egg. With the Zymot device, what's happening is that the group of sperm is going in sort of, let's call it, think of it as a cartridge, but inside this cartridge is an obstacle course for sperm. And so the sperm are able to run through this obstacle course. And theoretically, the best and the strongest are the ones that come out the other side, because those that aren't strong enough may get stuck inside the device. They can't make it past the obstacles. And so the best and the strongest come out the other side. And the embryologist then sits down with those sperm and selects individual sperm for each egg. So in other words, the embryologist is still able to make an individual choice about which sperm to place inside an egg, but they are making that choice coming from theoretically a better cohort of sperm, a better group of sperm from which to select. Is that beneficial for donor sperm? Well, I would say it's potentially beneficial for all sperm, although there is not great evidence that says that it should or could be used, or that it ought to be used in everybody. It's an add-on in most places. Now, where I work, we do something similar with sperm, and that's part of our standard sperm preparation. But to use the Zymot device in different places may cost a couple $100 as an add-on in order to theoretically select better sperm. Does that make sense? Well, with donor sperm, you never really know what you're going to get. So I would say, it is perhaps theoretically beneficial. I like it. If it was something that cost $2,000, then I would say, you know what? The data on it is slim enough that I can't say that that's worthwhile. But for a couple of $100 to potentially get better sperm for your group, I'd say, yeah, I think that probably is worth it, Andre, to me. And so now everybody has their own opinions on that. And again, most of the data, most of the evidence that comes from Zymot has to, actually came from the company itself. So they've done their own research and published their own research. So it makes you question it a little bit. But you know what? It does seem like a good idea. And given the possibilities there, I'd say, yeah, I think it's probably worthwhile. Let's see, let's see, we've got Midgie has joined us. Hi, Midgie. Now I feel complete. Thank you, Midgie, for being here. K.N. Davidson, A. Clark, Gaga Pammy, partner Dupma. Actually, that's my brother, partner. It is Roro. Hello, Roro. And is that really Kaylin from the Panhandle of Texas has joined, who is one of the most wonderful nurses in the world. And she is a rock star, quite literally is a rock star. And very happy to have you here this evening, Kaylin. Sarah asks, actually, I wanted to say hi to the Niceville esthetician. I like the name, and I can't see the picture there, but I think I know who that is. Deanna Guzzo, hello, good evening. And Sarah asks, after 90 days of Lupron and letrozole suppression, what would you expect the lining to be at baseline? Mine was 5.2, and I'm worried I didn't get suppressed enough. I go back Thursday for another remote check. Well, so you've been on a suppressive medication for endometriosis, and you had 90 days of that medication. The medication is Lupron, and what Lupron is literally doing is pulling the plug out of your hormones so that you go into a temporary menopause, which sounds wonderful, doesn't it? Doesn't that sound so pleasant, Sarah? I know that you were just loving that process. My guess is that during that process, you probably had some symptoms like hot flashes, symptoms like perhaps some vaginal dryness, symptoms like maybe some leg cramps, some mood change, some sleep disturbance. And I feel like if you had any of those, then you were suppressed enough. Now, we can do blood tests and look at your FSH level, for instance, and see that you are actually suppressed while you get the Lupron. But I've never seen a situation where Lupron does not adequately suppress someone, because that's just the way it works. And physiologically, I just haven't seen a situation where it doesn't work. I mean, it kind of has to work. And it's not just because we want it to work, but because, I mean, it just does. It turns to be, precise, it turns the pulsatile secretion of what's known as GnRH, or gonadotropin releasing hormone, which normally in our bodies hits us and then turns off, and it hits us and then it turns off, and it hits us and it turns off. It takes that pulsatile secretion of that hormone, which stimulates our things like our FSH and our LH, and makes the ovaries work. Instead of that, it goes to a constant stimulation. And with that constant stimulation, it turns off. It turns off the production. So that's how it works. It just kind of has to, because it's there. A 5 millimeter lining is really considered a menopausal lining. So I think that you probably got where you needed to be with that. I would consider that very adequate suppression there. So I think you can feel pretty good about it, Sarah. And Cowgirl says, hi, McDreamy from the girls. The Cowgirl there has a couple of very wonderful children who used to send me nice pictures, and I'm just saying I haven't gotten any for quite some time. Take that, under advisement there. But thank you for the kind compliment. Hi to Stephanie, who is recovering from a knee surgery, and hello to M. Sinclair. Good evening. Rosa says, can endometrial receptivity change for the second transfer with a 1-year gap between 2 transfers? Let's talk about that thing about endometrial receptivity. And before I do that, I just want to address something really quickly here that Sarah said over on the New Life Instagram side. It's very helpful. She says, thank you to calm my spiraling thoughts. I want to talk about spiraling thoughts because, our brains, and Rosa, I promise you I'm going to get to that question there in just a second. But this is really an important consideration. Our brains are built not so much to enjoy life as we know it out there in the world. Our brains are really built to perceive danger. Back in our, caveman or perhaps Neanderthal ancestry, a very large portion of our brain was built to try to detect danger. We didn't walk through the meadow and smell the pretty flowers and watch the beautiful sunset. We were constantly on guard. We were watching for that saber-toothed tiger to jump at us from the tree line. We were watching for that pterodactyl to swoop down and take our baby, and then it's gone. We were watching for that rival tribe to come in and club us to death and steal our food and our women. This is what our development was. And so that portion of the brain, the amygdala, is constantly on guard for danger. And when it doesn't sense danger, it may just make it up. Or when it thinks that something could maybe not be 100%, it catastrophizes. It starts finding reasons to make that worry just go on and snowball and start to spiral. That's what happens to us sometimes at night when you're trying to go to bed, right? Your brain just can't shut off. That's what happens with those spiraling thoughts. That portion of our mind that is always on guard for danger is doing really what it was hardwired to do, which was to find danger really maybe where there's none. That process in the fertility world is enough to drive us insane. Not just the fertility world, but that's what happens. That's what happens at home. It happens in work. It happens in relationships. It happens with regard to finances and what we're doing with money. It happens to everything in our world. Our brain is just constantly working to try to find danger. Not because it's trying to harm us, it's actually trying to help us. But in this world now of so much stimulation, there are so many possibilities of danger that that portion of the brain, quite frankly, gets really overwhelmed. And what happens as a result of that? We become the brain just, think of it as blowing your top. The brain loses control of its ability to be sensible. What I want you to remember when that portion of the brain is going crazy, it is just what we are built to do. And a lot of that is just noise. The only thing that we have is what's right in front of us right now. All that business about what happened before, all those things that we worry about, that we're depressed about, those things that happened to us in the past, they are purely figments of our imagination. They are constructs in the brain. They are gone. The anxiety about what may happen tomorrow is really just the brain worrying about the potential for danger, as opposed to what's in front of us at this moment. And Sarah, what's in front of you at this moment is that you got really well suppressed, that your uterus thought you were menopausal there with a 5 millimeter lining. Don't let your brain take advantage of you, friends. That's the lesson in that 2 minutes. So that's really honestly the truth. And our brain sometimes really can take advantage of us and put us in a very uncomfortable position. That's kind of what we talk about when we do the 5:30 fuzzies with Fink, but we'll get to that in just a few minutes. Let's jump back to Rosa. Endometrial receptivity. What is that? Well, it used to be that there was a test that we would recommend that some people do that was called an endometrial receptivity assay, or an ERA. That ERA was predicated on the idea that our uterus had a receptive window, a particular period of time during which an embryo could implant. And if an embryo showed up there and that period of time was wrong or it was off, then the embryo wouldn't implant. And again, predicated on this idea that 75% of us all have the same receptivity window, but that means that 25% of us don't. That's what the ERA was designed to look for. It was designed to try to show you your own personal receptivity window. Well, it was not an inexpensive test either. But as it turns out, the population data, when you look at it, shows us that, you know what? The live birth rate was not changed by doing this endometrial receptivity testing. And that we're really trying to make something black and white, that you're either receptive or you're not. That you're either within this window, which was 120 hours plus or minus 3, or you're not. And if you're not, then something about you is broken and it has to be fixed, because that receptivity window is controlled by the amount of progesterone you get. So that means we must alter that amount of progesterone. Otherwise, you'll never get pregnant. Well, guess what? It turns out that that just ain't a thing, that it's probably detecting normal variation in people's cycles. When you do an otherwise natural cycle, embryo transfer, it's controlled for. There is no 120 hours of progesterone. Your transfer happens on the day when it's supposed to, based on, when you've ovulated. So, Rosa, can the receptivity change? Well, we used to think that receptivity window was probably accurate for anywhere from 1 to 3 years. But I would tell you now at this point, if you had an ERA done and it showed something, and then you went on to get pregnant by doing something with that something, timing wise, I would stick with it. I certainly would not repeat an ERA. That is not a test that I really even offer anymore. There may, and I underline may, be some very, very narrow indications for it, but in general, it is not a test that has been validated to be meaningful at all. And in a specialty, or I should say a subspecialty here, where there is a lot of stuff out there that is designed to try to get you to part with your money, I do not recommend an endometrial receptivity assay. So Hopefully that's helpful there, Rosa. But can that receptivity change? Like I said, if it was a 1 year gap between two transfers, I would say that whatever you had before is probably accurate right now. And I would not, underscore not, do that test again. Marlena asks, can someone do an HSG while doing Lupron suppression to check out the tubes? Is it worth checking the tubes prior to a transfer? Well, so you can definitely do an HSG. So the HSG, or the hysterosalpingogram, is known as the dye test, where we place a little catheter inside the cervix and push some dye into the uterus to fill the uterus, see the shape of the uterus, and see if the fallopian tubes are open. That is something that you might do to determine whether sperm meeting egg inside the tubes is a viable option. Would you do that to look and see something else about the tube? And the answer is no, don't do that. One, it hurts. Two, it's expensive, right? It is not a cheap test to do. Three, it exposes you and your ovaries to radiation. But really, if what you're talking about there, you're talking about doing an embryo transfer, right? So you've already done IVF. Your tubes don't matter so much in the equation anymore. You've done IVF. Apparently, you've got endometriosis because now you're on Lupron for suppression, because we know that endometriosis can affect the way an embryo implants in the uterus. We know we want to treat that endometriosis for 60 days before we put the embryo in, and that fixes the endometriosis problem. What you're talking about there now is there an issue with the fallopian tubes? Like, do you have a tube that's filled with fluid? And that's what we know of as a hydrosalpinx. A hydrosalpinx. Do you have a hydrosalpinx? The recommended test for a hydrosalpinx is an ultrasound, because if it is a clinically significant hydrosalpinx, that is to say one that has enough fluid in it that fluid can back up into the uterine cavity and adversely affect your embryo transfer, then it should be visible by ultrasound with an experienced sonographer. And HSG is not the recommended test for that. So Marlena, I would say no, please don't let anyone talk you into an HSG for that reason. HSGs are not designed to show a hydrosalpinx. And the reason for that, just to be clear, is because let's say that your tubes are blocked. Let's say that you've got tubal factor fertility problems and that the end of the tube has some little blockage. Well, what's going to happen when you push some dye into the uterus? The near part of that tube is going to blow up, right? Because it's pushing against a blockage. And that's going to look like a hydrosalpinx, which means that somebody's going to say, oh, you need to have surgery now to remove that hydrosalpinx, when it's not a hydrosalpinx at all. It's something that is just a physical response to a distal blockage in the tube. It's what I would call an iatrogenic hydrosalpinx, which means we made it. The doctor made it. If there's really a blockage in the tube and the tube is full of fluid, an ultrasound will show you what you need to know. Ultrasound, way easier, way cheaper, way more comfortable, and best of all, no radiation. Now, I will tell you that there are a lot of places who will try to, will say, oh yeah, you need an HSG to evaluate the tubes. And I promise you that is not what the HSG is intended for. A very special good evening to Pui. My friend, I missed you on Sunday. I understand that you had a retrieval on Sunday. So I was at MCRM doing egg retrievals from Thursday, Friday, and Saturday. Met some really wonderful people. And I was really hoping to see you there, Pui, who I've seen the last few cycles. Pui has a wonderful, and I really do mean fantastic, Asian fusion type restaurant in the St. Louis area. And Pui, tell me the name, because I don't. Oh, actually, it is called. Oh man, I can't remember it now. But I was actually going to go there, and I ended up too tired to go out. Tell me the name, Pui, and I will give you that plug, because if you're in the St. Louis area, trust me, this is a place that you want to go. Tell me the name, Pooey, so I can shout you out there. Hi, Adage. Good to see you this evening here. I haven't seen anybody yet. I've got a bunch of people who are monitoring on the Facebook side, but nobody said anything. If you're there, please say hello. Pooey says Sushi Station. Thank you. Gosh, I was just having a mental block. If you are in the St. Louis area, Sushi Station is the place that you want to go because it is absolutely fantastic, as is its owner, Pooey. Fingers crossed to you, Pooey, and everything that you're going through. I'm sorry I wasn't there on Sunday, but if I had known it was going to be Sunday, I would have just stayed an extra day, you know? Gosh. Hey, guess what time it is? It's 5:30, and that means it is time for the 5:30 Fuzzies with Fink. What the heck does that even mean, the Fuzzies with Fink? Yeah, I'm pretty fuzzy, but that's not what we're talking about here. It's the warm and fuzzies. You know, this whole fertility thing, as we talked about a minute ago, with the spiraling thoughts and the brain that's kind of constantly on guard for danger. Um, um, this can be a very lonely place. Fertility is a lonely treatment place. And in fact, in this world with so much going on out there right now, the world can be a lonely place. And it is very possible to feel very much alone in a crowd of people. Well, that's what we do right now. This is the opportunity for us all to stand together as one community and to send out all the good vibes to everyone who needs it tonight. And that's not just the folks going through fertility treatment. That's not those people I saw brokenhearted this week who had negative pregnancy tests or who had a pregnancy loss. That's for people dealing with family problems, with work problems, with school problems, with relationship problems. You are not alone out there. The world can be a big, frightening place, but the important thing to know is that there are wonderful people who care about you. And I have always said that this group of people who joins my podcast here are the people who tend to be, would give the shirts off their back in order to be able to help someone else who is in need. And so now, if we could all join hands in kumbaya, let's do that. But since we can't, let's break the internet with kindness. The 5:30 Fuzzies with Fink is when we send out good vibes to you and to you and to you and to all those people out there tonight who need to know that we got this, that you're not alone, and that no matter what, tomorrow is a new day full of all new adventures. Hope is alive, my friends, and that is the Fuzzies with Fink. Please take that love from all of us to everyone tonight who needs it. And if you would, join me next week, if it's only for just a minute before 5:30, bottom of the hour, where you too can get all your friends to let's break the internet with kindness, is the way I like to think of it. If you're just joining, this is Fertility with Fink and Friends. And I am Fink and you are friends. And again, so wonderful to be here with everybody tonight. I'm live tonight from Pensacola, Florida, where I'm a fertility gynecologist at New Life Fertility, and I also work at the Missouri Center for Reproductive Medicine in St. Louis and Tulsa. Thanks for being here, and we're here for about another half an hour or so, so throw your questions my way, would you? Laura, good evening to you, my friend. I had my embryo transfer 4 days ago, and I had labs today. My estrogen was 800. Should I be concerned? And the answer to that is no. There is not really an estrogen level. So first of all, to be honest with you, checking a midway estrogen level is not particularly useful. Because my guess is, Laura, you may be using vaginal estrogen. And if so, vaginal estrogen typically makes that estradiol level go way high because it's absorbed very, very well through the vagina. If you're not using vaginal estrogen, and that's just from using your patch or from your estradiol pill, it is still fine. If that number is less than 3,000, I feel good about it, and I think it's okay. But be aware that if you're using vaginal estrogen, expect that that number is going to be, really pretty high. But that is okay. What estrogen has done was to stabilize that lining of the uterus and to get that lining of the uterus to grow so that you could have some progesterone and then get your FET. And you are using 3 estradiol pills a day vaginally. Yeah, well, so that's why your level is high. But the number itself is not something that you have to worry about there. So don't let the brain spiral on that one. It is all okay. You're in a good place. And fingers crossed to you, Laura. It's day 4, so that means, oh gosh, in just a few more days, hopefully you're going to get that positive test, right? Yes, indeed. Hi, Brittany from Facebook. Thanks for being here. You have a question about your next transfer. Well, lay it on. Let's hear it. I'm happy to answer it. And let's see who else we got here. We also have Kowser. Good evening to you. I hadn't seen you. I don't know, maybe you were here last week, but it's always nice to see you. Hi, V. Reese and Avis Barnett. Glad to have you here. C. Kits. And I really like it. It is Roro because that's a really good, that's a good handle there. V. Reese says, my husband and I have been abstaining, I think you mean, since Sunday for his semen analysis tomorrow. I got my LH spike today. Is it really important for us to abstain for the semen analysis? So you ask a very good question. All right. So first thing is, you got an LH surge. What does that mean? Does that mean that you're ovulating today? No, that's telling you that you are probably going to ovulate, let's call it 24 to 36 hours. Now, or even sometimes up to 48 hours. So the reason for abstaining before doing a semen analysis is because we want to try to maximize the sperm count so that we know really what's the best that you can do there. Typically, that's about 3 days. If the semen analysis is tomorrow, I would say go ahead and do the semen analysis tomorrow. And then go ahead and have timed intercourse, tomorrow night or even the next day, because sperm is going to live for about 5 days inside of you. And it's better to have that sperm there when the egg is released. But listen, if it's troubling to you with that timing or being able to keep up with that frequency of sexual intercourse, then go ahead and have intercourse tomorrow and just reschedule the semen analysis for a few days later. We say about 72 hours is the ideal amount of time to abstain in order to maximize the sperm count at the time of a semen analysis. So I would say, if you can reschedule it, sure, then, go ahead and have intercourse tomorrow. That sperm will be there when your egg is released, V. Reese, and hopefully all that timing will work out. And the need to even have to go and get the results of the semen analysis may not be there anymore, because you'll be like, why did I miss my period? And why are my breasts sore? And why am I nauseated? Doctor, what's going on? And I'll say, I think I know, young lady. Yes, indeed. So Brittany is back here. You're at MCRM in Tulsa, and you had your ultrasound and blood work today. Before my last transfer, Brittany said I had 2 polyps and wasn't aware of it. And you had them removed. I've heard that a fluid ultrasound and a pap smear can't always rule those out. Should I get another hysteroscopy like before my next transfer? So a pap smear, you're absolutely right, is testing for abnormal cells in the cervix, right, which is the opening to the uterus, and a pap smear would not pick up an endometrial polyp. A fluid ultrasound or a saline sonogram should be able to identify an endometrial polyp if it's there. Now, is it necessary for you to have another hysteroscopy? Well, I typically recommend that folks have the uterine cavity evaluated once a year when doing treatment. So my question really would, I'd have to wonder, Brittany, is when was that last hysteroscopy? When did you have those polyps removed, or when really was your last transfer? And if it was a year ago, then I'd say, yeah, I think it's reasonable to evaluate the cavity. Do a saline sonogram or a fluid ultrasound, but you do not by necessity need a hysteroscopy. Now, in my office here in Pensacola, we do office hysteroscopy, which is where we have a little tiny camera about the size of a wire that just goes through the cervix into the uterine cavity, and we can take a quick peek, and then we know exactly what's there. So that's one way, and that is certainly a way to evaluate. But I would say I would want you to evaluate the uterine cavity if it's been more than a year. But just because you had those polyps, typically they don't recur, or at least not in the same place. It would be very unusual for polyps to come back there, Brittany. So that would be my question. Oh, before retrieval in 2023. Yeah, so it's been a couple of years. I do recommend that you get yourself looked at in one fashion or another, either a diagnostic hysteroscopy or a fluid ultrasound. That's what I would do. Good evening to Zenaida in beautiful South Florida. Glad to have you here this evening. Thank you for being here as always. And it looks like Lilix 3, I think is what that says. Thank you for being here as well. Okay, Rosa says, is there any solution for postpartum hair loss? It's really horrible starting from 3 months postpartum. Any suggestions, please? So, this is an important thing to talk about. Postpartum hair loss, what causes that? Well, I'll tell you the reason that happens. And that's because hair grows in 5 different stages. And ask me what those stages are. I don't remember. I don't remember except for one of them. One of them is called telogen effluvium. Telogen effluvium. And telogen effluvium means that's the point at which hair starts to fall out. So at any given time, if you've got hair growing in 5 different stages of growth, 20% of your hairs are in any one of those stages, including that stage of falling out. And that's why, you can run your hands through your hair there and pull out, some hair. And that's really a normal factor at any given time. 20% of that hair ought to be able to fall out. And in fact, it may just fall out on its own, even if you don't pull it out. But that's why you see hair in the drain, and you see hair in the brush, and you see hair on the floor, because our hair just kind of falls out 20% of the time. Telogen effluvium can happen when that falling out phase happens when, instead of 20% being in any one phase, they get jarred. Some stress happens to the body. And guess what that stress is in childbirth? It's childbirth, right? So when that happens, all those things, instead of going in a separate separate phase, all get locked into one. And that one phase, it may be this phase, and then eventually it gets to this phase, that falling out phase. And then you get a boatload of hair that seems to be falling out. And that's the reason that hair falls out after you have a baby. You get into that telogen effluvium phase. And in most cases, telogen effluvium will resolve itself in anywhere from 2 to 6 months. But in the meanwhile, it can really make you feel like you're losing a lot of hair. And you can start to look at your hair as I look at my, actually, I'd rather not look at mine and see my hairline and how my hair is thinning, but at least I'm not like my brother. Yeah, you heard me. It can be something that becomes cosmetically noticeable if you're losing your hair like that. Hair is thinning, not just seeing bunches of hair in the drain, but when you look in the mirror. What can you do about it? Well, unfortunately, there isn't really a very good treatment that is designed that can alter that phase or those stages of hair growth. Now, I've seen products advertised on the market. It is said, I've seen, in fact, they just had it on TV the other day. I saw for Nutrafol, and Nutrafol said, they have a formula. That treats postpartum hair loss. And so I think, you can take all kinds of supplements that you want, but there really is no evidence-based treatment that is going to meaningfully affect that. Now, it may help you. There may be some formulas that help you grow new hair more quickly, but you will grow that hair anyway. So things like biotin. Biotin is said to help with hair growth. It didn't do anything for me, but maybe it'll do something for you. Actually, look what biotin did to me. It did this, and it did this. I used to have nothing, and then I took 3 days of biotin, and now look at me now. No, I'm just kidding there. So some of those formulas can help you to grow hair at a more maybe grow hair a little bit faster. But it is, in that scenario, it is not because of testosterone. It is not because of anything else hormonal other than the fact that you just had a baby. And so the body is responding to that stress by the the hair all shifting into that phase. That's called telogen effluvium. And you can look that up and see what that's all about. But it's a really good question, Rosa. And you are not alone, by the way. So when I practiced general OBGYN, that was a really common problem of folks coming in postpartum feeling like they obviously must have had some kind of hormonal abnormality. They want their hormones checked because their hair is just falling out. Well, it's true that you can, in theory, have a thyroid problem that leads to, hair falling out. But really, honestly, most of the time, that's not the issue at all. Telogen effluvium. Brittany says, so I need to schedule a hysteroscopy before my next transfer. It's been more than a year. I had my son in July of 2024. I had a fluid ultrasound and the NP said I was clear and good to go. I just wanted to be safe and get something in case they weren't showing up on the ultrasound. Well, so if you would like, Brittany, to have a diagnostic hysteroscopy, you certainly can. A hysteroscopy, hystero means uterus and scope means to look inside. A hysteroscopy is the gold standard for how we investigate the inside of the uterine cavity. Why is that? Because we look inside the uterine cavity, because we actually see it with our own eyes. Whereas a fluid ultrasound is an indirect measurement. What we're doing there, oh my gosh, I just yawned on you. I'm so sorry. I don't even know what to say about that. So what you're doing with a fluid ultrasound is putting some fluid on the inside that separates the top from the bottom layers of the uterus, and the fluid looks black. So if there's something in there that's sticking up like a polyp, sticks up like a tree trunk, or hangs down like an icicle, then if it's big enough, you ought to be able to see it. That's how a fluid ultrasound is done. If it was a smaller polyp, then it might not have shown up on a fluid ultrasound. But if it's that small, you have to ask, gosh, I wonder how clinically significant it is. But as I said, hysteroscopy is the gold standard, so there is no harm in having a hysteroscopy to investigate it. And I really do strongly encourage that your cavity be evaluated again before you do another embryo transfer. That is our standard here at New Life Fertility. And if it's a patient that I've talked to at MCRM, I generally do recommend that. It's just good sense. You've invested very heavily, right, to make that embryo. That is a precious embryo that you have there. That could be your next child. So you really want to know that uterine lining is just as beautiful as that beautiful embryo. And one way or another, I think it is definitely worthwhile to check into that. Question over here on the New Life side: what is the difference between Menopur versus Gonal F, and which group of women get prescribed one versus the other? Andre, that is a beautiful, wonderful, very intelligent question. So let's talk about that. These are medications that we use to stimulate the ovaries. These medications are called gonadotropins, and what they are is they're basically chemical versions of the same hormones that your own pituitary glands make in order to talk to the ovaries. That's the brain talking to the ovaries, and that's the chemical that they use. So instead of using your own, what we're doing in terms of stimulating the ovaries is trying to get you to produce either an egg or more than one egg in the case of IVF. So Gonal F and Follistim are two medications that represent the FSH hormone, or follicle stimulating hormone, FSH. That hormone, guess what it does? Can you tell by the name? It stimulates follicles. That's what it does, right? So that's the principal driver of growing eggs or growing follicles in the ovaries. All right. Now, Menopur is another type of medication, but instead of being called FSH, it's what's called HMG, human menopausal gonadotropin. So you're like, menopausal? I'm not menopausal. Why am I getting that? Well, this hormone was originally developed because it was, believe it or not, and if you may have heard me talk about this before, and it is the God's honest truth, this medication was originally developed from the urine of menopausal nuns. So they had this convent, and I've heard, I believe it was in Italy, but I think I've also heard that there's one that was in like Portugal, where the company would supported the convent by giving them money, to help them pay for all of their things and their food and so forth. And in exchange, all these menopausal nuns peed into special cups and collected it. Right. So not quite the same as holy water, I'm just saying, but don't drink that holy water. Just don't, but the hormone in that urine, and so of course it was quite a process to purify it and to take the hormone out of the urine and to get rid of all the other components of the urine. But that component was one that was also able to stimulate the pituitary gland. What stimulates that portion of the pituitary gland? The FSH. So there was FSH in that Menopur, but it's some different subtypes of FSH that's there. And it also has some of the LH hormone, luteinizing hormone. And luteinizing hormone is something that helps an egg to mature. It is something that you need in order to get an egg to ovulate and to go through its last stages of maturity. So, most people will get some combination of both gonal or follistim, or so FSH, and either Menopur, or there are some practices that really don't use a lot of Menopur. As you may know, where I used to work, rarely was Menopur used. They would use just HCG derived LH. So it came just from using HCG. And there are some situations where that's beneficial, and there are others where it's not. But most people in modern IVF practice get some combination of both the FSH hormone, gonal or follistim, and Menopur. Now, there are some situations where you can just use Menopur alone because it has both FSH and LH. But most of us typically will use the FSH hormone and either some LH from the beginning. But, honestly, if you are a diminished ovarian reserve patient, or if we have reason to think that maybe your eggs are a little bit more fragile, they don't need all that LH hormone in the beginning of the cycle. In fact, that can potentially even damage them. So I tend to like, for most people, to add the Menopur a little bit later on in the cycle, like by about day 4 or 5, because by that time, those little eggs, as they've grown, have developed the ability to respond to that Menopur. And that's a good thing at that point. So that's kind of the difference. And most people will kind of end up getting both in most cycles, unless you are at where I used to work. And typically then people will just get follistim or gonal, but mostly follistim and just HCG to function as the LH. And there are lots of thoughts as to why that might be, but that may be for another day. Let's see what else we got. Rugger, good evening. I hope you did not hear me say, I hope you did not see me yawn. That was, and I have a feeling you probably did, but Kaiser says, Doc, how are you? I had a laparoscopy last Thursday. I had a small spot of endometriosis removed. The right tube was open and a uterine septum was removed. Can I try naturally now, or do I have to go for IVF? Well, I think you can definitely, Counselor, I don't know the rest of your story there, but if you had endometriosis that was removed, if you have a left tube that is open and then the right tube was opened, but it may find its way scarring shut again. And if the tube was damaged, it means that, well, you will have some increased risk for an ectopic pregnancy because of tubal damage. That one had been damaged before. Even though it was open, you want to make sure that if you get a positive pregnancy test, that you follow that from the very beginning. I would say, yeah. And now the septum is gone inside the uterine cavity. Absolutely. Go ahead and give it a try. For sure. Logan, the therapist, my good friend there in Northwest Arkansas. Logan, I wish you had been here a little earlier when we were talking about the brain's response to guarding for danger and trying to be present and mindful and trying to turn off some of the noise when the mind is racing. Yes, here's my brother criticizing me again, and I'm not surprised because that's what brothers do. Yes, indeed. La Mujer, good evening. And Logan says, thank you. Lost track of time between dinner and new therapy puppy adding to the chaos. I hope you enjoy. That would be, that's fun. The puppy thing is a very fun thing. And thank you, Aaron, for watching me yawn twice. Appreciate it. And I only did that because I was hoping that you might be watching and so that I would give you something to comment on later on. You're welcome for that. Happy to be of service. Another thing that folks ask here a lot about, and it has to do with fibroids in the uterus. Fibroids are literally balls of muscle in the uterus that 75% of women are said to have some evidence of. So what is the uterus? The uterus is a little organ that is made of muscle. And if you feel your bicep here, you know that muscle comes together in little sheets. And these little sheets form that little hollow organ that is the uterus. And the job of that muscle later on is to be able to squeeze the baby out when that time comes. Well, when one of those little cells gets knocked off kilter, rather than forming a little sheet, it actually forms a ball. So a fibroid is literally a ball of muscle. Do they cause problems? Well, they can. They can. Are they a problem for pregnancy or at least for fertility? And the answer to that is it really kind of depends on where the fibroid is. So a fibroid can be inside the uterine cavity. And if a fibroid is inside the uterine cavity, that's a problem because it's taken up real estate. It's taken up real estate that would otherwise be used for a pregnancy to implant. Furthermore, it may be that it's got actually some endometrium or uterine lining that's sitting on top of it that's unstable. So it's just not a good place for a pregnancy to implant. If it's within the walls of the uterus, it may have an effect on pregnancy because what fibroids do is that they tend to try to recruit their own blood supply, which means that a lot of people with fibroids have heavier menstrual bleeding. Fibroids can grow large and can cause bulk effects, like making you feel like this increasing abdominal girth, or that you can't get your pants, buttoned. Believe me, I feel like that every day. It may be that it sits on top of your bladder so that you kind of feel like you have to go to the bathroom all the time. These are common kind of fibroid symptoms. And in these cases, it might be worth getting those fibroids addressed. If a fibroid is within the wall of the uterus, it may have an effect depending kind of on where it is and depending upon how big it is. The other concern is that when fibroids get large, they can absolutely have an impact on pregnancy. Because they have changed the way the blood supply goes to the pregnancy or to the uterus itself, that can affect the placenta. That can create situations where there may be growth issues with the pregnancy or with your baby because of that large fibroid. There can be issues related to preterm labor. If you required a C-section, there can be issues with where is that fibroid relative to the incision that has to get made on the uterus. All these things are a concern, but if it's an issue for you, it's a good thing to talk about it with your doctor because fibroids are not all the same. They are not. And just because you have a fibroid doesn't mean you have to do anything about it. Again, 3 out of 4 women have some evidence of fibroids in the uterus, which means, gosh, it's really pretty much a normal variant. So small fibroids, 1, 2, 3 centimeters, they really don't do anything to most people and do not need to be addressed. Fibroids are problematic when they're causing problems. That makes sense. They're problematic when they're causing problems. They're problematic when you're feeling them. They're problematic when they are causing bleeding issues, bulk symptoms. Those are the kinds of times when it needs to be addressed. But if you're trying to get pregnant and you have fibroids, good time to ask your doctor because that's when expert advice is oftentimes helpful. Folks, we're going to be out of time for tonight. It has been a fun evening. Oh, one last question here. Alpha lipoic acid for egg retrieval. Yes, alpha lipoic acid is on the list of evidence-based supplements that can help us with egg quality. So yes is the answer, 650 milligrams. And that also is a very, very positive thing for sperm as well. You may recall seeing a post that I did about that. There was a study that looked at males taking alpha lipoic acid, men who had sperm issues, and they found that the number of pregnancies doubled. They doubled in people taking alpha lipoic acid. So it affected the sperm parameters that well that I do recommend it really for every male out there. So if your partner's not taking it, maybe it's time to start. All right, folks, guess what? We'll be back next Tuesday at Fertility with Fink and Friends. In the meanwhile, you know, I always close the show saying the same thing, and that is that this fertility business is not the book of your life. It's just a chapter. And what are we here to do? We are here to rewrite that chapter together. So until next time, know that every step forward can be made with love. Every step forward should be made with kindness. And every step forward must be made with hope. Because tomorrow is a new day and it is full of all new adventures. So until next week, I'm Dr. Randy Fink in Pensacola. Thanks so much for being here and good night. See ya.